So we're switching
You want to use this one? Yeah.
presenters. So we have the great luck to listen to Rachel Gur-Arie. Is that how you pronounce it?
Perfect. Yeah, yeah.
Who's going to talk about implementing ethical and equitable vaccine mandates for healthcare workers. The floor is yours.
Thank you. Thank you so much for having me. So like Jeremy said, my name is Rachel Gur-Arie. I am a bioethicist and health systems researcher, assistant professor at Arizona State University, which is in Phoenix, Arizona. For those of you who don't know, Arizona is north of Mexico, east of California. So it's a very unique kind of location in the United States. We're a desert, it's very hot, it's like 40 degrees Celsius there all the time. I didn't have clothes to come to Paris at this time. I was like, what do I wear? It's cold out. No, I'm just kidding. But so as a health researcher there, we have a very unique kind of population in terms of the fact that we're very diverse. We have a lot of Latino population and a lot of Native American population. So those aspects really influence myself as a bioethicist. Today I'll be giving a talk mostly on the ethics of vaccine mandates. So I wasn't going to come here and give a talk on health systems research or vaccine uptake or hesitancy research because we have many amazing people who have done that already. But I hope that this talk will give kind of a framework for better understanding how to use ethics in terms of justifying or not justifying vaccine mandates. Okay, so this is a brief overview. It's really important for me to define what exactly I mean by these terms because I feel like, especially in the American context, they're just like thrown around like they have no meaning. So it's like vaccine hesitancy, it's like as if we all agree on what that means, as if we all know what a mandate means. Most people actually don't really know what a vaccine mandate is. Everyone in this room does, but actually most people don't. And it's been very politicized in the United States context. And I think I might be the only American here, which is also unique for me. So I'm not used to being able to talk about this kind of subject with such nuance without getting like canceled or called like anti-science or something like that. I mean, I love America, I love work, I love living there, you know, I love my country, but I will say that the debate there is very, very polarized. And as we saw earlier, it's not gonna get any easier kind of over the next 4 years. Okay, so some kind of assumptions that I make in the style of philosophy style. So these arrows don't mean causation, they mean, you know, influence or correlation. So vaccine hesitancy is correlated with low vaccine uptake. Therefore, sometimes when there is low vaccine hesitancy, there is low vaccine uptake, so we consider vaccine mandates as a policy option. Vaccine hesitancy does not equal vaccine mandates, which is like a really big thing, at least in US public health right now. Like vaccine hesitancy is thrown out around in the way of like, if there's vaccine hesitancy, let's just like mandate everything right now. And if you like question that, then you don't believe in public health and you don't believe in science. And so actually to be able to even kind of fully agree with this last premise is pretty revolutionary right now, at least where I'm working. I don't need to show this figure to everyone here, but I do when I'm back home in the sense that we define vaccine hesitancy, or I do, as a spectrum. Vaccine hesitancy is not anti-vaccination. Anti-vaxxers are one very small portion of the spectrum of vaccine hesitancy, which includes ultimate acceptors, which we don't want to admit, but a lot of people, at least in the American public health system, are here, okay? They're actually not here. And so it's very difficult to be representative of most of the American population, at least. This is 85% of the American population, when you are working in a public health academic setting that everyone is here. Okay, because you're unable to understand these people, you're certainly unable to understand these people, and therefore you're unable to build trust with them, and therefore it's like unbelievable to you that people don't get vaccinated, when in fact, it's actually very understandable why people don't get vaccinated. I'm citing one of Katie's earlier papers here, so I love this figure in terms of better explaining vaccine mandates on a spectrum. This is also how I interpret a vaccine mandate. We could technically say that complete voluntary vaccination is a mandate. I mean, it's kind of weird to say, but a voluntary policy, meaning that you're not penalized doing one way or another, is on the spectrum of vaccine mandates all the way to going to prison, being very, very heavily fined. So both hesitancy and mandates, as I engage with them in my work, are on a spectrum. Therefore, it's really, really hard to have like point blank, direct, clear kind of ethical takeaways and policy recommendations on a high theoretical level. The details really, really matter here from an ethics perspective in my work as well. So here is kind of a bioethics framework that I like to reference that is more on the applied side. It's out of the Nuffield Bioethics Council, which is based in the UK. So mandates are the most intrusive kind of public health intervention, which I think, especially coming out of COVID, we're not fully engaging with this fact, in my opinion, all of the time, because we're so used to using mandates over the last 5 to 10 years, maybe. But in fact, they are the most intrusive kind of intervention. And in public health, at least the kind of public health that I was trained in, you try and do everything else before you mandate. Okay, you don't just like realize that a disease is coming and jump to mandating unless you have done really significant work and you can provide a really excellent justification. Mandates eliminate choice, which from an ethics kind of framework is a really, really powerful and careful thing you have to only do when you absolutely, absolutely need to. Oop. Okay, so vaccine hesitancy, in my opinion, does not justify vaccine mandates. We need to make a case for vaccine mandates, and this is the role of bioethics. And I think also in the public health discourse today, and certainly throughout COVID, it was like, vaccine mandates are ethical because the benefit outweighs the burden. But then we just heard Judith earlier say that, well, people, that's not very convincing to healthcare workers. In fact, that can actually be harmful because if you're even engaging with any kind of risk at all, it turns people away. Yet ethics in public health and clinical discourse is oftentimes like, the 4 principles, autonomy, justice, beneficence, non-maleficence, if we've talked about those things and we've checked the box of ethics, it's difficult for me as a bioethicist to hear that, but I know that that's the reality in a lot of clinical settings. That's okay, but we shouldn't dilute it all the time like that. So, in my work, I kind of view vaccine mandates as a response to different kinds of cases of different kinds of vaccine uptake levels and diseases. So the first kind being just the fact of the risk in itself of not getting vaccine uptake in a community is unacceptable. We don't even want to go there, so we mandate the vaccine. In the case of polio or an MMR, we don't want to see a case of polio, so we mandate it. We're not going to test and wait and see what happens because then we're going to get polio and MMR. We don't want that. Therefore, we implement a mandate immediately. Or maybe we don't implement a mandate immediately. We see that we have low vaccine uptake in a community, and that's threatening for whatever reason that we want to define later. And therefore, we might mandate because that risk is unacceptable. Maybe flu and COVID are an example of this. And the last one is really interesting and kind of sad in a way because the case diseases are similar to the first, and this is the reality in the US right now. So we have existing low vaccine uptake, which has already caused outbreaks. So we're already seeing polio resurface. I did my PhD in Israel. There's polio resurfacing in Israel right now. It's unbelievable. It's very sad. That is preventable. There's measles right now in schools all across America now, where we should have mandated that in the first place, but we didn't, and now we're seeing them reemerge. And that's the failure, I think, of public health. So, transitioning now to the ethics of healthcare workers. This is how I like to show how I conceptualize healthcare workers. So healthcare workers are a lot of different people who come from a lot of different backgrounds. We expect a lot of healthcare workers from an ethics perspective. We expect them to be honest. We expect them when we're traveling if we're traveling in a country outside of our home and we're sick, we expect them not to kill us when we go to the hospital. We expect them to save our lives. These are just things we take for granted. But there are a lot of values that are interesting to explore that we won't, that are associated with healthcare workers. Healthcare workers also treat the most immunocompromised in society, the elderly and children, which are all populations that are most susceptible to illness. And then healthcare workers are also made up of a lot of different occupational groups, as we've touched on. What I'm most interested in kind of moving forward 2025 and beyond in this work is really looking into what non-clinical essential workers mean as a healthcare worker. They're often overlooked. These are food staff workers, janitors that still work in the healthcare system and are impacted by our policies, but we usually think of nurses and doctors when we think of healthcare workers. Okay, so I'm going to harp on the ethics for just a little bit longer and then kind of transition to the point. So with colleagues, we wrote a paper on the two central kind of ethics premises for mandating COVID specifically mandates for healthcare workers, one being a public health justification, which we've heard earlier, that their unique occupational risk puts them at higher risk of contracting diseases, therefore there's a public health justification for mandating vaccines for healthcare workers. And the clinical justification, so there's a duty to do no harm to your patients, therefore you should get vaccinated against COVID. So beyond the fact that we need the highest level of justification for vaccine mandates, from an ethics perspective, we also need a moral justification, which is going to vary culture to culture. So like I said, I'm from the US originally, but I did my PhD in Israel. We're right now in France. I work now in a different part of the US. So every single one of those regions has a different moral justification for why we should mandate a vaccine. That's why different countries have higher or low rates of vaccine uptake fundamentally, but that's a different story. And they also require collective buy-in. So the mandate in and of itself is not going to translate to outcomes. The implementation is what translates to outcomes, which requires collective buy-in. So I'm going to wrap up here with the equity concerns that I started getting into a little bit when I was talking about different occupational groups. So we talk about vaccine mandates a lot as like this behemoth. We talk about healthcare workers a lot as this like homogeneous group. But in fact, like the implementation of mandates, in my opinion, and I'm really interested in doing more work on this, has the potential to disproportionately burden underserved populations. For example, women make up 70% of the global healthcare workforce. So if we are implementing a healthcare mandate that fires you if you don't comply, that means maybe we're firing mostly women with that mandate. In the US, for example, we're maybe firing mostly black women with that mandate, which I think is really interesting because the interest in vaccine mandate research in the last 5 years in the US coincided together with this movement toward equality and equity in health, racial inequality in health and minimizing inequalities. So it was really interesting to me to see the same people who were calling for universal mandates, blanket mandate, if you question the mandate, you're anti-science, we're not gonna talk to you because you're stupid, potentially, stuff like that. At the same time, we're calling for racial, equality and to minimize health inequities. To me, those are contradictory because if you really wanted to minimize health inequalities in America, you would recognize that we have a diverse healthcare workforce, and to implement a mandate means hurting the people that you want to help the most in practice. And this is an area where I really want to dive more deep into my research. I feel like it's really not looked into at the moment. Also, just from a pure occupational perspective, different healthcare worker groups have more or less at stake. So if I'm a rich surgeon who makes $1 million a year, I can quit my job because I'm rich, and I'll go find another job that doesn't require me to get mandated to work, especially in the US. You can kind of pick, okay? But if I'm a poor, or a lower socioeconomic status person, and I'm undocumented potentially, and I'm working as a medical tech in a clinic, I have to comply because otherwise I don't have a job and they're gonna send me back home, especially today with the new administration. Okay, so how do we go towards equitable implementation of vaccine mandates for healthcare workers? This is not the answer, but these are points that I would encourage folks to keep in mind when trying to do so. So consider the extent to which the vaccines protect not only the person getting vaccinated, but as well as others. So transmission really matters when it comes to justifying mandates. We kind of forgot that, I feel like, in the ethics discourse in the last 5 years, but that is really the bread and butter of the ethics of vaccine mandates. Recognize that the stronger the protection there is to third parties, the stronger the ethical case for the mandate, but still understand that there are risks for implementing mandates, like hurting trust in health, potentially turning people away from the medical establishment that you have to take into consideration. And then also engage healthcare workers as early as possible. Don't just come to them when you need something from them, which is what healthcare systems are really good at doing, but try and kind of know where they stand before the next pandemic happens so that you're not completely shocked when 50% of your healthcare workers quit when you implement a mandate. Like a lot of, there are a lot of states in the US where they lost the majority of their workforce, like in certain hospitals because they implemented a mandate because people didn't want to have a mandate. If you would have just asked them, maybe they would have gotten vaccinated, but the fact that you told them that they had to, it turned them off and they quit. So it's, you have to know the people who work for you. Okay, I wanted to just give a plug for the current research that I'm doing. So someone mentioned here earlier that vaccine uptake status and political affiliation are like correlated in the US, which is true. But actually the #1 determinant to vaccine behavior in the US is your religious status, which in my opinion, then we need to research religious vaccine hesitancy to understand political determinants of vaccine uptake, which then will help us moving forward. So there's a project I'm doing with psychologists at ASU, funded by the Templeton Foundation, which is a foundation that funds like a lot of philosophy work, focused on religion and vaccine hesitancy. And then I'm really excited because in like a day or two, this correspondence is going to come out in Nature with my colleague Ben Caston-Davish at Edinburgh, just like begging people not to stop vaccine funding because that's probably what's going to happen like in the next, who knows when, maybe in tomorrow, maybe in 2 weeks, maybe in 5 months, we don't know. But it's no secret that Kennedy, if RFK Jr., if confirmed, will gut public health, but not only gut public health, he will gut vaccine funding. This is beyond vaccine hesitancy. This is just funding for programs. And, that's really bad. We need to have money to vaccinate people. So thank you so much for inviting me to the organizers. And yes, thank you.
Thank you so much for this presentation. Questions? Ev was the quickest draw, and then it's Dawn.
Thanks, Rachel, for your presentation. Really nice. I really like the vaccine situation-based analysis, which I think is often overlooked, and it seems vaccine mandate seems to be a quick fix to vaccine hesitancy, which is not the case. Have you researched at all the impact of trust? Because just different intervention could lead to same result. In Canada, Ontario has childhood mandate, and the rates are lower than in Quebec, whereas then there's no mandate, but there's more initiative like reminder, recall, checking vaccine status. They're system-based, and that helps increase uptake better than mandate. And I feel that the mandate often action is on whether people check if you're vaccinated or not. It's on the enforcement. That's when it make an action. If you do take this action, otherwise it might preserve trust and have the results. So are you looking at these? I know you're doing qualitative research, or are you trying to get at those trust factor and the impact of mandates on how people see the vaccination systems?
Yes, so I haven't been able to do a new study since COVID, just because especially in America, it's so polarized and it's very hard to get funding if I were to propose that word by word, but I'm thinking of ways to creatively investigate that. I will say, I mentioned I did my PhD in Israel, and actually throughout my dissertation research, I ran around hospitals there, chasing after healthcare workers in their hospitals, asking them why they didn't get vaccinated against the flu, because there was a flu mandate, but uptake levels were so low. And it's the only reason that the system was able to maintain trust among the healthcare workers, even though there was a mandate, is because it's not enforced. So that's a cultural thing. So like they're okay with the mandate, but don't you dare enforce it, otherwise we're out, kind of thing. Also the government is the healthcare system, which is then their employer, so it's a little different. But yeah, so I got to a lot of that early on in my PhD, and I would love to explore that more if there's anyone who wants to do that. So thank you, yeah.
A lot of stuff on that.
Okay, yeah.
In France, we've had mandates, for instance, starting all the way to basically now, we have mandates that were not enforced. We can talk about it.
Okay, sure, yeah.
Oh, okay. Yeah, thank you. That really resonated with me because, so what your point on the groups that are more affected, because in the UK, I'd spoken in the previous talk about the mandate for healthcare workers being repealed before it was enforced.
Yes, exactly.
But they did actually enforce one for social care workers, so people who work in care homes, which is a very strange order in which to do things. But then if you think of the profile of who's working in care homes, largely immigrants, largely women, and those health professionals who do have a bit more power to sort of rebel against it. Sorry, if that's the kind of context, but my question's a bit more philosophical, and it's maybe related to Eva's point. Do you sort of, what do you think about mandates as being treating kind of the symptoms of hesitancy and low uptake as opposed to the causes, and the dangers of doing that, especially in the context with the mandates are only as strong as, say, the state that are willing to put them in place? Just taking the case in America, for example, I imagine that they're probably going after any vaccine mandates that are in place now, and then if the root causes of low uptake have never been addressed, then you're sort of right back to square one. So I wonder if you had any comments on that. Sorry, it's a bit
my
heavy
comment
question.
is like, yes, like I just agree with you. I mean, mandates are a Band-Aid solution from an ethics perspective. I mean, and I think also in practice, like you put a mandate in place to quickly raise uptake in the hopes that then you get those rates up and you can do the real work. The problem is then now we're relying on mandates to maintain the uptake levels, and then we're surprised when people are more distrusting of public health than ever. It seems like that would make a lot of sense. You're not engaging with people, you're telling them what to do. And I think what's also overlooked in the jump from zero to mandate is like, if you just talk to people, if you just make it free and put it in front of their exit in their work, like you can achieve really high uptake rates. Like a lot of the time people aren't like ideologically against this. They just don't have time. In America, they don't have insurance. Like especially people who are working 10 jobs, like they don't, and then the vaccines are only offered at the same time their kids are in childcare. Like especially in the States, the systems really don't make it any easier. So yes, it's a Band-Aid solution that isn't going to help us in the long run, in my opinion.
Yvon?
I was wondering if when we talk about mandate, do we accept or think of obligatory mandate to be tested? You know, because in Switzerland there were no mandates, and they did relatively well about. And so there were in Switzerland a mandate to be for. I'm talking about healthcare workers to be tested regularly. I don't remember how much in a week, but that was it. So it's another kind of mandate.
Yeah. I mean that, like on the Nuffield scale that I showed earlier, like that would be a reasonable alternative to the vaccination requirement. So I think from a public health perspective, that's, I think, again, ethics perspective, that's positively viewed. In practice, you'd have to evaluate if that testing was was equivalent to vaccination. Because certainly in the case of polio, you can't just have people opting out of the polio mandate and then continually getting tested for polio. That's not a reasonable alternative. So I think the word reasonable alternative is really the key there from an ethics perspective on that case.
So the second microphone died. Judith, I'm going to ask you to come here to... Can you come here to ask a question? Because we're a bit constrained.
Thank you, Rachel. So I was wondering about the consequences of a mandate, you know, of non-respect of the mandate, because as you showed, everything is actually in there, the details. Have you found any reflection on that? You know, a mandate that is not enforced, does it really make people happy or angry? Whom does it make happy and angry? What are the consequences of mandates that are not fully enforced, or are they actually a good option?
Thanks for the question. So actually, I think, like, in fact, at least in the places I've done research primarily, so the US and Israel and a little bit of the UK, but I'll just talk for the first two. People don't have a problem with mandates, really, because most of the time, I mean, when you think about it, mandates weren't some big political something on your mind until recently, maybe the last 5 years, at least COVID. I think people are liking it when mandates are not strictly enforced. I think people, on average, I'm thinking about a school mandate in the US as well as a healthcare worker mandate in general. People are reasonable on average, so they understand they work in a place or they send their kids to a place that have this rule. And I think that, and really until recently, it wasn't so polarized. So maybe some people were angry, but they were always the minority. I mean, I know Katie has done work in California with these communities who traditionally were more hippie communities and against mandates and against vaccination in general. But in fact, I don't think that people have that big of issue with mandates. I think it's turned into something much bigger in the last 5 years that more research has to be done to quite understand what happened. But I think it's best to enforce the mandate as little as possible in order to generate appropriate results, and think with your brain to understand what appropriate result is. So like with flu vaccine uptake, maybe 50% uptake is a successful mandate implementation because it's not worth it for us to waste all of our trust on getting from 50 to 60% with the mandate. It's just not worth it for us. 50% is better than 20%. But maybe we do go to bat and push people more when it comes to a measles implementation or a polio implementation. So it's that kind of nuance where it's hard for me to answer that question in general. But I think I like to believe people are reasonable on average.
Cette fois, c'est non. No, it's time to move on to the next presentation. Thank you so much for this great presentation. We'll have a lot to talk about. We're going to welcome Yvon